Hi, my name is Dr. Stacie Groat. I'm a physical therapist and I specialize in orthopedics, so shoulder pain, back pain, hip pain, neck pain, and then I also specialize, and this is more my passion, is in pelvic health. So that is treating urinary leakage, pelvic pain, constipation, pain with sex, prolapse, which I'll go over in a little bit, and diastasis rectus abdominis. So I help you get a bit of sunshine where the sun don't shine. So yeah, I want to bring back the vibes to your lady parts. So this is something near and dear to me because every week I hear different stories about patients who are going in through to perimenopause and the conversations that they have with their providers. And so something that stuck out to me recently is I was talking with a patient. She came in to see me for prolapse and rectal pain, and she was telling me that a year ago she went to her provider and she told her that she was having night sweats. She was having this really stubborn, like she wasn't able to lose weight when she was trying all the things, exercise, eating healthy. She was having these pelvic floor symptoms like overactive bladder and prolapse. And she told her provider this, and the provider said, "This is your new normal." And sadly, I hear these things every day. And so all of the people who have spoken today are going to be your advocate, and so I would highly recommend working with any of these people. So just make sure start like building your team of providers and make sure you're finding someone that's going to advocate for you, because obviously also we just have to be our own advocate too. So yeah, we'll go to the next slide. So some fun statistics. One I didn't include on there that I forgot to mention in the last session that I wanted to bring up is that men start losing muscle mass at 55. When do you think women start losing muscle mass? 31. Yeah, so this was so sad, like, right? So I'll talk about strength training more later on, but just keep that in mind. It's just not fair. So a lot of these statistics, you're going to see things that might be really common. This does not mean that they're normal. So you don't have to live with these symptoms. So 1 in 3 women are incontinent. That's insane. 33% of us in this room, right, have urinary leakage or maybe fecal leakage too. 1 in 4 women have pelvic floor dysfunction. So that can be prolapse, diastasis rectus abdominis, pelvic pain conditions, urinary incontinence, overactive bladder, versus 1 in 10 for men. Like, come on, that's not fair. If this was men, there would be so much research devoted towards this, right? 20 to 59% of peri and postmenopausal women report pain with sex. I think that number is probably closer to the 50%, at least what I see clinically. And my practice is about between 40 to 50% perimenopause, postmenopause. 50% of women have some degree of prolapse, and I've seen some studies that show that 90% of women who deliver vaginally have a prolapse. So it's super, super common. Prolapse, you can think of it like a hernia in your pelvis. So it's when your pelvic organs descend into the vaginal canal, and people will feel symptoms like heaviness or pressure. They'll feel a bulge. They might feel like something's falling down vaginally. Might feel like you have a tampon inside. And unfortunately, the 2 times that we see these symptoms come about is pretty immediately postpartum. And then as your estrogen levels start to climb again, people start to feel better. And then perimenopause, these symptoms come back. But we have really effective treatments for it. So that's good. 70% of women who are perimenopausal have musculoskeletal pain syndrome of menopause. So meaning joint pain, muscle loss, muscle weakness, osteopenia, or osteoporosis. But what was surprising to me is 25% of those 70% will become disabled due to the pain associated with musculoskeletal syndrome of menopause. So that's a huge number, right? And these are things that we can prevent, so that we don't have to have these major life shifts or changes. Something going on disability is I mean, we live in California; it's so expensive here, right? So, okay. And then the last one is, I believe it's 84% of women who go through menopause will develop genitourinary syndrome of menopause, and I'm going to go over those symptoms on the next slide. Okay, so these are all of the symptoms of genitourinary syndrome of menopause. So I'm going to kind of go through them and explain all of them. So stress urinary incontinence is urinary leakage with coughing, sneezing, laughing, jumping, running, any movement. Urge urinary incontinence is when you have a really strong urge to get to the bathroom, but you don't get there in time. You may have a few drops, or you may have like a full-blown accident. Overactive bladder. So if you're someone who had to go to the bathroom at the beginning of this session and you get the urge during this panel, again, you probably have overactive bladder. I'm sorry to tell you that. So that's anyone who goes to the bathroom more frequently than every 2 hours. No matter how much water you're drinking, even if you're like drinking water all day in, day out, you should be voiding every 3 to 4 hours. So if you're going every 30 minutes, you probably have overactive bladder symptoms. Pain with insertion. So during perimenopause, our estrogen levels change so much, and this I probably see a lot postmenopausally because our estrogen is so decreased. And as Dr. Phyllis said earlier, all of the cells in our body have estrogen receptors, and our pelvic floor loves estrogen. And so when we have that decrease in estrogen, it causes atrophy of your pelvic floor and thinning of your tissues, which can lead to pain with insertion. So that could be pain with like inserting a finger, pain with gynecologic exams, or pain with intercourse. Pelvic pain conditions, so that could be pudendal neuralgia, which is a feeling of like discomfort in the perineum. Painful and heavy periods, this is what we see a lot during perimenopause because your periods are changing so much. Rectal pain, vaginal pain, urethral pain, pain in your vulva, constipation. So you have a saying in pelvic PT that you're constipated unless proven otherwise. Constipation could be, you could be going every day, but you may not fully be emptying your bowels, and that's considered a form of constipation. If you have pelvic floor tension, that can lead to constipation. Fecal incontinence, so that can be anywhere from total loss of stool, or it could be you have staining in your underwear. And then pelvic organ prolapse, which I mentioned earlier, so that's when your tissues so during perimenopause, all of our tissues, like the fascia, the connective tissue, the ligaments, and the pelvic floor, are all impacted by that decrease in estrogen. And so that will cause symptoms like tissue heaviness or pressure. And people will feel that when they're standing for prolonged periods, when they're jumping, when they're picking something up off the ground, carrying a kit, like a bigger kid who's heavier, they might start to feel those symptoms more. Recurrent UTIs, so because of that decrease in estrogen and the atrophy in the pelvic floor, the walls of the urethra actually become thinner, which makes it much more susceptible for bacteria to penetrate, and we can be more susceptible to recurrent UTIs. Lichen sclerosis is an autoimmune condition affecting the vulvar tissues, which will cause like a thinning. Common symptoms with that, because this is a sneaky one, is itching at night. With that, a lot of people will think they have a yeast infection, and they'll persistently go get treatment for it, and it's not getting better. And then, unfortunately, with that, because it is autoimmune and progressive, it will cause the lining of the opening of the vagina to become very thin, that people will actually tear every time they have something inserted. So getting earlier intervention of that is really important, and also, if this is not treated, it can lead to vulvar cancer. So this is one thing I didn't mention in the last one. We should be checking our vulvas monthly, just like you do breast checks monthly. So what you're gonna do, it's not very fun, but it's very important. You're gonna take a mirror. If you're postpartum and you're like, I don't know if I'm not ready for this, don't do it yet, you're fine. You take a mirror, look at your vulva, and then you also wanna touch, and you want to see if you feel any differences. And it's just like a breast exam. You have to do this monthly in order to know if there's something inconsistent, because you might feel something different, right? And you're like, what's that, right? And then you go and speak with your gynecologist, and they can, do a more thorough exam. But monthly vulvar checks are really important in this phase of life. Vaginal dryness, also a result of decreased estrogen, and then itching too can be a result of decreased estrogen. Okay, so next slide, please. Okay, so what is the pelvic floor? So the pelvic floor is a group of muscles that sit at the bottom of the pelvis, and they attach from the pubic bone, I'm just gonna hold this down here, pubic bone to the tailbone. And these are the muscles in red. So the outer layers support the urethra and the anus, and the deeper layers support the pelvic organs. And they're like a bowl of muscles at the bottom of our pelvis. So they support our pelvic organs. I had a patient who came in with her husband, and he was like, do I have a pelvic floor? And I was like, why, yes, because if you didn't, you would just have skin holding everything up. Isn't that sad? That's how men never have to think about their pelvic floor, right? Until they have their prostate removed. So your pelvic floors provide you stability. They support our organs. When we have failure of that support system, which is the fascia, the muscles, the ligaments. That's when we can get pelvic organ prolapse. If we have pelvic floor tension, we can get conditions like pain with intercourse, overactive bladder, difficulty emptying the bladder, or difficulty emptying the bowel, because the muscles surround the urethral opening and the anus. Okay, this is my vulva that fell off. Yeah, that happens sometimes. If we have pelvic floor weakness, then we can have symptoms like urinary leakage, fecal leakage, difficulty passing our gas, and also difficulty achieving orgasm. So we'll go to the next slide. Oh, actually, so really briefly, I want everyone to do a Kegel right now. So the cues that I like to use for a Kegel is I want you to imagine you're either closing off the muscles around the urethra or the anus, like you're trying to stop yourself from passing gas. Or my favorite cue is I want you to pretend like you're picking up a blueberry with your vagina. Or sipping a smoothie with your vagina. It works. Okay. So what you should feel is your muscles lift away, okay? If you really want to get in there, you can actually feel like around your sit bones with your hands, but maybe for another day, I don't know. You're welcome to do that though. Nothing's ever TMI with me, I've heard it all. And so you should feel a lift and a bulge, okay, when you do that. And it is easier to do this if you can feel with your hands. So if you feel the lift, but you don't feel the muscles bulge, and you have prolapse, urinary incontinence, overactive bladder, then it could be a sign that you have pelvic floor tension and you would benefit from a physical therapy evaluation. If you feel nothing, then it's a sign that you might have pelvic floor weakness and you would also benefit from a physical therapy evaluation. So some effective treatment strategies for urinary syndrome of menopause. I had a patient who came to see me for urinary leakage, overactive bladder, and pain with sex. And so I worked with her provider to give her some local vaginal estrogen while we worked on her pelvic floor tension. And within 12 sessions, she had complete alleviation of the pain. She was having really pleasurable sex. She wasn't having any overactive bladder symptoms, like her UTIs had gone away. So very, very impactful. Physical activity and exercise is just great for your pelvic floor health. So pelvic floor therapy is not just Kegels. I had a patient in yesterday who has urinary leakage with jumping. We didn't do a single Kegel in the session, and she left feeling like she got a workout in. So full body exercise is actually really, really good for your hormone health too. Strength training goes along with that. Okay, so this is kind of a fun study. So vibrators, they've done a couple cool studies over the past years, and I'm just very curious as to who signs up to be a participant for these. I'm like, sign me up. No, I'm just kidding. So there was a study that came out a few years ago that's 20 minutes of using a vibrator actually helps to increase your pelvic floor strength weekly. Just 20 minutes a week, that's it. In a survey done in 2024 of postmenopausal women who regularly used a vibrator, I'm not sure what the frequency of that one is, reported decreased depression and anxiety, decreased overactive bladder symptoms, decreased prolapse symptoms, and decreased urinary leakage. So break out that vibrator from your bedside table. And yeah, like I said earlier, pelvic floor therapy and topical estrogen or hormone replacement therapy works really well together. So we always like to collaborate with other providers too, to make sure patients get symptom relief. So now talking a little bit about the musculoskeletal syndrome of menopause. So that refers to any joint pain, muscle pain, sarcopenia, which is loss of muscle, osteopenia, and osteoporosis, and that's when our bone density decreases because of that decreasing estrogen. So this can present like neck pain. It can, because of the decreased estrogen, inflammation goes up, right? So that can lead to all of the itises, like Achilles tendonitis, plantar fasciitis, frozen shoulder. So frozen shoulder, the really, really good evidence to support physical therapy plus cortisone injections for improving mobility with frozen shoulder. Hip pain, low back pain, knee pain, shoulder pain, foot pain. So all of these, our joints can be impacted by the decreasing estrogen levels. And then the other thing too you want to think about is because people aren't sleeping as well during this phase of life, and I have a 9-month-old baby, so I feel like my pain is elevated when I don't get as much sleep, but when our sleep levels, or we're not sleeping as well, pain goes up. That's just been proven study after study. So hormone replacement therapy can help with sleep, right? So that can also in turn help pain. Then that stubborn fat that's difficult to lose, unfortunately, it puts more pressure on our joints, and that can lead to more inflammation and irritation. Can we go to the next slide? So as I mentioned earlier, 70% of women will develop some pain associated with menopause. This is why strength training is a total non-negotiable. So I was saying earlier, like in the earlier session, if you're in your 30s, start strength training. If you're in your 40s, 50s, 60s, your 20s, start strength training. Tell your daughters to start strength training. All it takes is 2 days a week, trying to train the full body. And then you want to make sure you're not just doing like machines at the gym. You want to be like in contact with the floor, squatting, push-ups, doing deadlifts. The stronger our muscles are, the more our joints are supported, and that's going to help with decreased pain. Yesterday, I had a patient who has, and like now thinking that she may be starting to be in perimenopause. She's in her late 30s. She came in to see me for back pain and sciatic nerve pain, and she's had this pain for 10 years. And she's gotten injections, she's like never gone the surgical route, thank goodness. But she's just in this constant cycle of having to get cortisone injections every 6 months. So she's finally out of the pain, and yesterday we started doing some strength training. We just did some squats with some dumbbells, and she was like in tears. She was so happy. She felt like she could never do this. Like she felt so empowered, and she was like, who am I? So I feel like I got teary with that too. But we want to make sure we're not in pain when we're doing strength training too. So physical therapy or chiropractic with Dr. Pearl can help with pain management so that we can lift heavier. The number one thing I always tell, the easiest thing to do is go out and buy a weighted vest. You can buy them on Amazon. I think you can buy a $20 one on Amazon, and then just start walking with a weighted vest, because that helps with increasing bone density. Another statistic is that the top 2 reasons that people go into nursing homes, number 1 is falls. Number 2 is incontinence. So So these are all things that we can treat, right? Any of all of us providers up here can help you prevent that. So I'll just finish with a patient story. So I had a patient, changed her name for HIPAA reasons, but let's say her name is Jen. She came to see me from a workshop that I did at her yoga studio, and she had urinary incontinence with jumping and with jumping jacks and jump rope. And she really liked to go to this yoga sculpt class where they do a lot of jumping. She also had overactive bladder, so she felt like when she would go out to run errands, she would have to find a bathroom somewhere. So that's another thing. If you're a person who's like, I gotta go to the bathroom just in case, sorry, you have overactive bladder. So she had overactive bladder, and she also had this chronic low back pain with sitting, which now thinking about it, she probably has musculoskeletal pain syndrome of menopause. And so after we did an evaluation, we actually found that she had a lot of weakness in her pelvic floor, and by strengthening her core and her glutes, strengthening her pelvic floor, she's now to a point where she can go to her sculpt class and jump as much as she wants. She doesn't have back pain anymore with sitting or with lifting. And she feels like she can go out for 3 hours and run all of her errands without having to worry about her bladder anymore. So she told me at the end of our sessions is that she doesn't have to think about her pelvic floor and her bladder anymore, and that was really empowering for her. So I just want you all here to know today that you don't have to live with any of these symptoms, and I would love to help you. So I'm doing a workshop with Dr. Pearl next month here. That's going to be more interactive, so we'll be exercising and more solutions oriented as well. And then also the questionnaire that I put out, if you have any of those symptoms, it's just a nice checklist to see if you'd be a good candidate for pelvic floor PT. So yeah, you don't have to suffer. Thank you. Any other questions?
When it comes to UTIs, it's interesting to me that over the years, it's changed how often we're recommended to go see the gynecologist, and now they're pushing it 5 years. They say if we're not active sexually.
Yeah.
How often do you think we should see the gyne?
Yearly? Annually?
Yeah. Thank you for that.
Yeah. I think that's so I know after 70 you don't even have to go at all anymore, right? That's what I've heard. And then I've not heard 5 years before. I thought 3 years for a tap.
Yeah.
It's changed.
Yeah, they keep pushing it.
I swear Kaiser recently told me 5, and I was shocked.
Yeah,
I swear when I was younger, it used to be maybe 6 months or a year.
Yeah.
And then it's 3, and then it's 5, and I've noticed a lot of people don't realize when they have the UTI.
Yeah. Yeah.
They don't always have symptoms, and then they discover it in the ER when something else happens.
Yeah. So that local vaginal estrogen can really help with preventing UTIs during menopause and after menopause, and that can be taken throughout the life, and it's really not absorbed systemically, which is kind of nice. So if you have any like reservations about taking HRT, then local estrogen is great. There's an amazing physician. She's a urologist specializing in female sexual medicine called Dr. Rachel. Her name's Dr. Rachel Rubin. She's such an amazing advocate for women's health. I would recommend following her page because she's just so knowledgeable. But yeah, good question. I would say like if you have any symptoms, then go to your doctor, right? And if they just say, like one of my patients also said that her doctor said, "Welcome to the club," and I was like, okay, I don't want to be in this club. Any other questions?
I have a question.
Yeah.
But I'm currently a patient, and if you have any hesitation, 110% just recommend an assessment.
Thank you, Megan.